I just wondered if we could ask our international keynotes as well to comment around, from their experience, any words of wisdom for us around how to ensure that we don't widen any health inequities as we start out on this journey.
You want to start?
Sure. One topic that is dear to my heart, but I did not have time to present, is algorithm bias. So people think that computers are more objective because they don't have the cognitive biases that humans have, but it turned out that if you feed a computer biased data, you're going to have biased algorithms. So every time we create a model, we make doubly sure that the model is performing consistently across different populations. So I think a famous story that came out 3 years ago was a software that's being used by judicial courts that were found to be biased against blacks and Hispanics. So they were overestimating the risk of blacks repeating the crime versus whites. And clearly that could happen in healthcare. You could have an algorithm that will predict that a certain marginalized population will not respond to chemotherapy just because they were not represented in the original training cohort. So that every time you, as I said, at the end of an algorithm, what you would like to do is to really make sure that it performs equally well across different populations. And even if you've done that, you don't stop. You keep evaluating the algorithm over time to make sure that it keeps its accuracy over time. And I'm completely against patenting algorithms. I think algorithms should not be patented because algorithms have very limited application in terms of its performance. It's limited in time and space. So don't think that if you build a model from Auckland Hospital that you could use it in Dunedin Hospital. You're going to have to recalibrate that. And don't think that if it's working in Auckland Hospital, it's going to be working 2 years from now. So I think the revenue would come from a company that will continuously test those algorithms and recalibrate that algorithm according to the population. But data should not be sold. Algorithms should not be patented. That's my personal view.
Well, I think that's important, fundamental of the bias that's embedded in algorithms. But there's another story here that's even bigger, which is the potential for AI to promote rather than reduce health inequities. And I was really moved by your talk and found it really educational to learn the situation here. But perhaps the U.S. is the home of health inequities because there's no insurance for 30 million people even after the Affordable Care Act, or the Unaffordable Care Act. So what we have is the dilemma here that, as you mentioned, the cost of the technology with Moore's Law and cheap chips is remarkably little. Algorithms can be produced very inexpensively, relatively. So if we were to give these to people who have are indigent or just of lower socioeconomic strata, where we know there's a really profound risk factor for all sorts of morbidities, if we were to give these, there's a chance that we can actually reduce inequity. But that remains to be seen. I think that there's a phenomenal opportunity here to move this in the right direction, but we haven't a good precedent for that. Like, for example, now we don't give out smartphones and data plans to people, where that's already a way to start to nurture care, self-care, and improve overall access. But here we're talking about a much more powerful means, which is the ability to promote diagnosis or guidance, coaching, that sort of thing.
Right, thank you. I have some questions on here. One from Richard Medlicott, GP. So he's asking, in New Zealand, how do we access valid AI tools? As a GP, I would love to upload ECG to screen heart failure or dermoscopy photos. So I think Richard's really raising this issue that Eric also touched on briefly around this, what they're calling the AI chasm. But how do we go about moving from research into practice and having these tools actually embedded and available in clinical practice? Anyone like to start on that one?
Well, I just would go on to your point about what we have called, Pierce Keen and I, the AI chasm, which is you have these incredible algorithms with AUCs of 0.99, and they're validated in multiple populations in multiple places, but they have no evidence of clinical impact. And we have lots of those right now. And they may wind up actually transforming medicine, making it better, more accurate, and less costly, and quicker, and everything else. But we got to have that proof. So that's the chasm right now that exists. We've got lots of fancy claims regarding accuracy, but not in a clinical environment or not in the real world.
I mean, the first step, you cannot get an AI tool off the shelf and start even testing it, evaluating it among the Kiwis. It needs to be recalibrated here. And for that to happen, you need data. You need well-labeled data coming from New Zealand. And where would we find that? And that data, as you know, is probably in different servers, not connected, so that the outcomes are in one system while the features are in another system. So the first step really is to build your data resource. And that's one of the reasons why we're here. We're hopefully egging you to follow our example in terms of really connecting the dots, connecting data coming from different systems, being mindful of privacy and security, obviously, and making that data available to as many investigators as possible. To me, the university is a rich resource of talent. You don't need MIT to come here. You have enough geniuses and local talent here to be able to take advantage of your own data. But right now, I don't think that that data resource is in existence. And you need that before you could even calibrate and evaluate any AI tools that comes from anywhere in the world or even in New Zealand.
My viewpoint's more from a data user, because I'm not clinical. I did medicine the easy way. I married it. And but although she's a specialist, she can't actually even drive her tablet, so I don't think there'll be any AI happening in her practice. One of the issues for me as somebody who is deeply interested in this is the fact that our very, very good data sources in New Zealand are siloed, and we can't actually join up the clinical pathway. And we can't join up the best data sources for some of the social determinants of well-being that we know are really important for what we see in primary care, emergency care, secondary care. So one of the things I'd like to see is some policy debate, and again, this is somewhere where people in this audience need to be heavily engaged in, to start joining up those bits, even at the regional level. Start at Auckland, right? This is something we should be able to do in Auckland, and the technology is there now with the new recent advances in accessing secure and confidential data in ways that doesn't compromise confidentiality or security. Names of the software escapes my mind, but there has been some project. One of them is N1 Analytics out of Data 61 in Australia. So the technology is there now to start doing this analysis across data sets, but we need some push by data users, and we need some brave data holders to make it happen.
It's a very good point. Your initial response leads us to one of the other questions that has come from Kai around the challenges with clinicians and IT professionals and data analysts all working together. And I think it's of note that two of the most important, influential international speakers in this area are both clinicians, both you, Eric, and Leo. What's the importance of having clinicians on board? How do we get them involved in actually the very early stages of the research, so that we ensure that we're approaching the right questions, the right data, as Andrew says, and for the right kind of benefits that we want to see?
Education is key. We need to start with the young clinicians, the young data scientists. Somehow they need to have some understanding of the other world. And also, even earlier during their education, we need to train them to be able to work together. And that's not really something that we're doing now, not here, not in the United States, not anywhere. The educators for medical schools and especially for medical schools, are not as familiar with machine learning and AI, and for that reason, data analytics is not incorporated into the curriculum as much as we wanted to. To us, this is a skill that will be used across different specialties, no matter what specialty you go into. Again, we are now in the information age. There's no point memorizing cranial nerves or memorizing types of beta blockers because you could easily look that up. What you need to do is to learn how to learn and be able to really understand statistics, understand causal inference, understand machine learning. And I think the future doctor provider will be an information specialist. Your role there is to be able to navigate patients across all these probabilities and trade-offs and be able to elicit their preferences so that they understand the numbers better. Unfortunately, we ourselves don't understand the numbers, so how can we guide a patient to navigate those probabilities? So somehow there has to be a big change in the way we're training doctors and nurses and pharmacists. And it's also in the way we're training data scientists now.
Yeah, I think this is an important point about the fact that you have clinicians and data computer scientists working together. One of the things to bring back the bias story, an example I tell in the Deep Medicine book, which is really interesting. There was I mentioned the potassium blood level on the watch determination, which is remarkably accurate for high potassium. So the cardiologists at Mayo Clinic believed that that was a T-wave story, and they just kept telling the data science people at this little startup, AliveCore, that just work on the T-wave, and it came up completely blotto, nothing. And so they said, well, why don't we just look at the entire cardiogram? And then they cracked the case and they came up with, so there was a bias on both sides. But together, these minds came up with the right answer and solved the problem. The other big complementary aspect is knowing where the unmet needs are. The computer folks are not so great at that. They are really good at a lot of other things. And that's where clinicians know where, we make the errors and we really could take things to unprecedented heights and accuracy. So I think that's important as well.
Okay, so that's we have. Okay, we'll go to the floor. Who's our first?
Hi, my name is James McAfee. I'm an ophthalmologist, and this is a question for Leo. I thought your talk was really great, by the way. Thank you very much. And I was particularly interested in your comments regarding our ability to measure physiological variables with a whole lot of devices and so on with high sensitivity, and how that can lead to overdiagnosis and over-testing. And I just was wondering if you had any thoughts about how can we reconcile that with the fact that, in many countries we have health systems with very finite amounts of resource that, potentially could create a massive problem.
So I think, you're absolutely right. There's so much concern about really skyrocketing the over-diagnosis out there. And all you'll be doing is making an entire population worry about nothing. So one way to address that would be when we start selling these gadgets, we have to be very clear that this is being done for research purposes, that whatever we'll discover may not be something that you need to be worried about. And the research that's being done now is probably going to benefit your children and your grandchildren, but it doesn't mean that we need to act on it now because we've never collected this much data before, so we don't know how to interpret that. Unfortunately, it's being sold now to improve your health, even though there is no evidence that being able to detect this, even AFib, I'm pretty sure that there are lots of people who may have AFib all their lives without knowing about it in the middle of Africa, and yet we're going to be discovering every single one of them now. What is the effect of that to the entire population? So I think we have to be very thoughtful about approaching this, measuring every physiologic signal there is, because we could easily be harmed by all the information that we're getting.
Okay.
Thanks. Thanks for all those talks, really great. My question is from a patient point of view, or thinking about the care of relatives and things. A big problem that I see that wasn't on your list, Leo, was about a kind of integrated care where trying to get an overall sort of integrated view of one particular, your own, what's going on for you between all the different specialists you might see and between different institutions and different doctors, in the sense that there's no one person who understands the system and is advocating and sort of gets the whole picture. Do you see any, and amongst the stuff you've been talking about, any possibilities for ameliorating that?
My personal bias is to improve the health literacy of the entire population and have them be the captain of their ship and really be in charge of their data, be in charge of their care. I think there's a lot of room in terms of how we can do that. Like, we're teaching them calculus, we're teaching them quantum physics, and yet they don't understand health as much as we would like them to, including being able to analyze data. So I think that's one pronged approach to addressing that problem. I'll be interested to hear the opinions of the other speakers.
Well, I'm a big proponent that each person should own their data and break out of this paternalistic mode where doctors believe they own the data and health systems, but they own the data, and it shouldn't be theirs. It should be yours to consent to share with these entities and people. And we have to get out of that, because we really can't make the advances that lie ahead without that new established rightful ownership model, which I believe should be a civil right for all societies. We have to really, it's a big change to make. The other thing is education. We touched on it. So in Finland, they just announced a program for all citizens in Finland to teach them about AI just this week. And that's a step in the right direction. So the combination of having the data to be able to decide who to share it with, whether it's a medical research program or whether it's for one's own care, and the ability to get better up to speed as to what are the liabilities as well as the strengths of this technology are important.
And there are different ways of doing that. The very earliest successful data-driven health initiative that I mentioned, that was a credit card-sized piece of cardboard with the patient's asthma information on it, and they were taught to be their own asthma navigators through the healthcare system. So it doesn't have to be high tech. There's some really fantastic stuff coming out of the whānau water providers, especially those funded by Waitemata, who have actually got wraparound whānau-based, extended family-based information, and they're supported in going through the healthcare system with a navigator. Now, that's not a permanent relationship. It's about upskilling somebody so that they can use both the information and the services that are available to them in an appropriate way.
Hi there. Thanks very much for really engaging talks. So I'm Randall Britton from Auckland District Health Board. I'm Head of Data Science there. It's a new role. I think there's a lot of talk about clinicians and the population in general learning about AI and machine learning and so on, and there's really no excuse not to. There's so much material available to do that. At the same time, I think different people, especially from the point of view of clinicians learning to understand AI and apply it, go into those careers. People who become data scientists, I think I'd like to encourage and find out what we can do about enabling those types of people, engineering types of people, to understand more about medicine, how it's practiced, as well as underlying physiology and so on. I think we shouldn't just be encouraging everyone to go into all the machine learning MOOCs. It should be the other way around as well. There should be a whole lot of medicine MOOCs so that the engineers actually really understand the body of knowledge about medicine. So any comments from the panel on that?
So this afternoon and tomorrow, we hope to see all of you there. This will be hands-on workshops designed for both clinicians and data scientists. It's an introduction to machine learning, natural language processing, image recognition, causal inference. And then, as I said, next year, we're hoping to really have 2-3-day intensive datathons where you really dig in with a question coming from you. So what are you interested in? And then let's start looking at data sets that are available here in New Zealand. Let's start integrating them over the next year and see if we could make them available to the students as well as the young professionals who are interested in this career. So the database that we have, it's not just limited as well to academia. I mean, we know that the large companies are using Mimic and the EICU database. Startup companies are using it to start, getting some experience with working with high resolution, very noisy data. So we think that people always hesitate. We don't want to open up our data yet because we don't know how dirty it is. What I say is that just do it. I mean, there's no way you could clean up a data set enough so that it's going to be ready for machine learning. What we've done is we crowdsource that because it's a very, very laborious task of cleansing the data, curating the data. But if we could share that task among thousands of students who are under the supervision of people who are very familiar with that data set, then we could accelerate this process. And that's really what we're hoping to achieve with these events. I know that they're fun, but they're also, there is an objective behind these data-thons. It's not just for us to travel around the world. What we're trying to do is to change the culture on the ground and really try to transform your attitude towards data and the way you work with each other.
Hi, Andrew with the Canterbury District Health Board. We've seen some really interesting use cases as stuff that seems quite bleeding edge, and I'm wondering what does it take for an organisation to get to that point where they can leverage that kind of stuff, given that for many DHBs in New Zealand, collection of meaningful data may be a sort of very secondary concern.
Well, I've seen here in Auckland the most advanced AI avatar that exists in the world with Soul Machines. And that came, I think, out of people here at the university, that Mark Sager and others. So, I mean, as you pointed out, the ingenuity is here, but it's just defining what what is the initiative? What are we going to go after? That there's a remarkable opportunity, and I don't think there's any yet avatar that's been established that even competes with it that I've seen.
We've had several. Go ahead.
For me, there's a couple of issues of scale, and one of them is in terms of scale, in terms of data sets, so we can actually get the level of precision that we need, and that means we need to join things up, right? And we're never going to get this at one single DHB, with the size of one small suburb in New York. Right? And secondly is in terms of scale, in terms of expertise. We're never actually going to get lots of well-rounded, multi-talented data scientists in any one location. But maybe what we could do is follow the model that Genevieve Bell is using at the 3A Institute at ANU, which is she's putting a multidisciplinary team that even involves lawyers. Okay, that is the bottom of the barrel, but they even involves lawyers. And the idea there is that they are going to create templates that other people can adapt in locations. So I think that's one approach that we could use. And MB's about to re-advertise their data science bid for $50 million, if anybody's keen. And I think there's a real opportunity there to create that kind of scale that could be rolled out.
Well, I mean, what you've touched on is the biggest limitation of the whole field, which is annotated, labeled data sets, large, and it's a big paucity relative to non-medical sectors. And that's where China has this big advantage. And that's why China is leading this space. And there's a book by Kai-Fu Lee, Superpowers. He also, if you can download the segment, he was on 60 Minutes just this past Sunday. And that's why they're ahead. And places that have small populations and don't have massive annotated data sets have a disadvantage. That's why maybe that's not the way to really try to get an edge in AI. I mean, even though you're going to get them all trained here, I know.
Yes. No, we've been having meetings with the ACC, and tomorrow you'll hear a summary of the discussions that have been going on. And I was privileged to see an extract of the treatment injury data set. And these are all claims that have been put forth over the last decade about potential hospital-acquired injuries. And there's nothing like this in the world. Like, this is the best corpus to study patient safety. Anywhere in the world, there is no good labeling of potential errors in the hospital because everyone is scared of reporting it. But since here there is not really a fully no-fault system, you get reporting of everything that could possibly be a treatment injury. And there's a way to build a system where you could use an algorithm to, in real time, predict a treatment injury. And to me, this is the corpus to start with. Build some natural language processing to extract information from the notes from the claims and see if you could relate that with some, data coming from the hospitals, and build a real-time system that will alert you there's a potential for a treatment injury tomorrow. You might want to look at all the medications that you're giving and all the lab test results that you've been ordering. But I was very excited when I was looking at this data set. Like, no one has this in the rest of the world.
But a complementary way is to take, as you alluded to, really well-validated algorithms developed elsewhere, and to then do the implementation phase in the clinical, in a real environment. And there, you don't need the massive data sets. You just have to have the will and the rigor of doing the testing. And there's a big deficiency of that right now. So, we're pretty good at algorithmic production, but very poor at this latter phase of implementation and proof.
Just to let you know, we're planning to go for another 10 minutes and shorten your lunch break, if that's all right with everybody.
Kia ora. My name's Chad Parane. I operate in the Māori health space. I'm with ACC and PDH and a few other bits and pieces. Look, I've got a question around applicability. And I guess a lot of the examples that I've seen in the kind of emerging AI space is kind of hospital-based, acute care-based, right at that kind of acute and high-intensity secondary tertiary space. We've got big kind of groups in this country here who are struggling with the basic access to healthcare issue. You mentioned 30 million Americans in Obamacare and things like that. We've got those issues here. And I'm curious, are there examples where AI, and I guess that precision-based kind of healthcare space, has actually shifted upstream in terms of pre-primary community-based care, access through and into the system? Are there examples where AI is kind of being applied in that space and having some sort of impact?
Well, the first one that's out there, is diabetic retinopathy, which is a serious underdiagnosed problem leading to treatment and prevention. The hope is there'll be many more examples. That there are many in the hopper right now, but that is a nice reflection of how early we are in this field. So I think that's where we want to go, but there's not a lot of tangible evidence that we're there yet.
Do we have another one ready, or I have one here? Okay, while we're doing that, we have a question from Rinky Murphy. Yes.
I'm Karen Gray, University of Auckland, and I'm a health information. I'm very interested in all of this amazing talent that you're talking about and what AI can do for us. What I'm really interested in is how we have built all this incredible stuff into the workplace, into the workforce. What do we need to do with the workforce for this stuff to be usable?
Well, I can comment on that, at least from the vantage point of the US and also the UK, that most clinicians are suffering burnout, big time, depression, and in the US, a record number of suicides. So it's a very bad state right now. And there's lots of theories about why it has gotten to this state, whether it's just the lack, I think, and you may have other feelings about this, it's largely because people that went into the profession to care for patients are not being able to do what they had hoped and intended to do. So that's where I think could be one of the greatest outgrowths of this effort, which is to decompress the clinician's life as it exists today and make a lot of those tasks done through deep learning and other algorithmic support. But the real problem lies in if that leads to a more squeeze among clinicians to see more patients and do more things, read more scans and slides and all that, then it's a bust. It'll just get worse. And this is really the time for the clinical community, which tends to be passive, to stand up and say, no, we're going the other direction. We're going to use the future to bring back the past, which was an intimate relationship and time, the gift of time. So I think that's the biggest priority right now of AI, is to establish that. And that's when we bring the humanistic qualities back to this, where we've lost our way in many respects because of the squeeze. Oh.
And being married to a grumpy clinician, I can tell you that one of the things that drive her crazy is the paperwork that data-driven systems require. And so I think there's it should be a requirement on anybody producing a data-driven system to simplify the process of data collection as much as possible, and the new data linkage tools means that most of the field should be self-populating. There should be no need to spend 3 minutes doing a smear and 20 minutes doing the form.
So I would just plug again Eric Topol's review paper on Nature Medicine. I was reading it. I read it twice actually, and I was very heartened to hear about companies who are now investing into computerized scribes. So I think what's going to happen in 5 to 10 years is that we're not going to be writing down notes anymore. There will be an Alexa and Siri listening to us while we're talking to the patient, while we're doing rounds, and it will automatically capture the record of the patient. And so that we could really spend more time just talking to our colleagues, collaborating on the plan for the patient, obviously bringing in the patient, eliciting their values. So I think the new SMART is not about what we know, but how we listen, how we communicate, how we collaborate. So to me, the role of the doctor, the nurse, and the other healthcare providers are going to be completely different 10 years from now. And I could tell you part of that team is going to be a data scientist.
Agreed.
Great. I'll just do a question from the app, from Rinky Murphy, is an endocrinologist. A question for Andrew. How do you see Māori data sovereignty in relation to making data publicly available, as is policy for several journals in genomics and metagenomics?
Oh, easy ones. Okay. That is a really tricky question. I'm, as somebody who uses that data as a researcher, as an advocate, and is also an interested family member, I am absolutely against the sending any Māori Indigenous genetic material overseas and therefore losing control. And I am against any publication of genealogical information. So no member of our whānau is allowed to use 123 me or anything like that. However, there are different ways around it. When they discovered the CDH when they published that in Nature, they actually obviously had to publish the family tree, right, and the hereditary pattern. And so what they did is they had a discussion with Nature and said, well, actually, we can't put the real thing in there, but we'll give you something that looks like the real thing and behaves like the real thing, but it's not the real thing. Is that okay? And we expected a fight. And Nature went, yeah, sure. As for putting microdata out and publishing it, no. Straight, simple, no. If it's able to be identified as Indigenous, right? And that is because you can tell stories about collectives with that. That means that and we have a process of both individual and collective consent that is required, and you cannot get the collective consent for publishing a collective resource.
Very good. Okay, I think this may have to be our last question. You want some lunch?
I don't mind, that's fine. I'm Valia from Canterbury DHB. I've got a question. What do you think about automated machine learning platforms? Do you think it would be our future? Do you think the need for data scientists would increase or decrease with coming all those new technologies on board? automated machine learning platforms?
Automated machine learning platforms. I don't think you can exclude the domain experts from this. I don't think you could completely automate any machine learning task without the involvement of someone who really knows about the data. So I'm going to be very pessimistic about that particular field.
Being convinced to do one more quick question, and then we will break for lunch.
And we're still around during lunch too.
Great.
Hi, my name is Manish. I'm from ADHB, working as a data scientist. Recently, I heard a talk on ethics of AI where the speaker was arguing that we don't really need an explainable or interpretable AI, but we need a reliable AI. The example he gave was of a thermometer. He said, not everybody understands how a thermometer works, but it's very reliable and we do understand the temperature readings that it gives us. So I just wanted to understand your thoughts on interpretable AI versus reliable AI.
So that's a really central controversy. It isn't settled. So if you had an algorithm that was phenomenally accurate and it was tested in the clinical environment and you had no idea how it was working, would you use it? And there has been some legislation in Europe with the GDPR saying, if it's not explainable, it can't be used. In the US, that hasn't been adopted. But that's a real question. And if you ask clinicians, you'll get different answers. Would they trust it and use it just because it has a black box and it's not transparent? A lot will say, sure, if it really helps. And others will say, no, I want to know. But I think that's really a little silly because there's so many things we do in medicine that we have no idea why they work, whether it's medicines or whether, we give diagnoses, and we don't know. So to expect machines to always be explainable, whereas we don't expect that of humans, seems a little bit of a irony, I guess. So this, I think, is going to stay as a controversy for some time, and there is the whole explainable AI movement. But are we going to hold hostage the progress of the field to that? I don't know what you think.
So, I completely agree with you. I hope that those doctors who are pushing back against AI, if it's not interpretable, are also not prescribing paracetamol because we don't know how paracetamol works. I hope they're not prescribing propofol or they inhale anesthetics because we don't know how those work, and yet they're using it. So
how about ECT therapy of the brain? No one has a clue. So many things in medicine we don't have any idea. So why are we going to hold machines so much more? It's a fascinating question, and it does bring up, as you say, the crux of the ethics,
Ending on more questions seems to be a good way to close the panel. Please join me in thanking very much our very distinguished